Can we have the third speaker, Dr. Sowmya PERI? She'll be speaking on Eyes of the Future, predicting visual acuity in pediatric corneal trauma and traumatic cataract.
So, Eyes of the Future, predicting visual acuity in pediatric corneal trauma and traumatic cataract. Introduction. Ocular trauma is an important cause of preventable visual morbidity and acquired unilateral blindness in the pediatric age group. The knowledge about epidemiological, socio-demographic aspects, causative factors, visual outcomes assumes special significance in trauma-related blindness of a child, as a child suffers from more blind years than that of an adult. So the aim of the study is to study the incidence, demographics, clinical profile of ocular trauma in pediatric patients and evaluate factors influencing final visual acuity in postcorneal trauma cases, blunt or penetrating with adjunct traumatic cataract. A retrospective study of 15 pediatric eyes who presented with unilateral corneal tear with adjunct traumatic cataracts were reviewed. We evaluated age at trauma, gender, trauma type, blunt or penetrating injury, cause, zone of injury, duration between trauma, primary corneal tear repair and cataract surgery, IOL implanted and BCVA. So coming to the results, high prevalence of ocular trauma was seen in males as compared to females because of more engagement in outdoor activities. Patients with OTS score of 5 had a relatively better visual outcome. Zone 1 injuries were more common in our study. Blunt injuries outnumber the penetrating ones. Most injuries in our study were caused by objects such as wooden sticks, pencils, metallic objects, stones, glass pieces, vegetative matter, which cause more of penetrating injuries. So coming to the main results table. So 6 out of 15, that is 40% cases with penetrating injuries had primary corneal tear repair followed by traumatic cataract extraction, IOL implantation 4 to 6 weeks later. 3 out of 6, that is 50% cases, had a visual acuity of 6/18 or better. 9 out of 15, that is 60% cases, had blunt trauma with adjunct self-sealed corneal tear or scar and had primary IOL implantation earlier. 7 out of 9, that is 77.7% cases, had a visual acuity of 6/12 or better. So here is an example of a 3 mm corneal tear. After primary tear repair, the vision was 2/60, but after IOL implantation post 6 weeks, the vision improved to 6/9. Another example of an inverted L-shaped 4 into 4 mm corneal tear. After primary tear repair, the vision was 2/60, but after post-IOL implantation, the vision improved to only 6/36 because of the dense stromal scarring in this patient. So dense stromal scarring, vitreous hemorrhage and retinal detachment contributed to poor visual outcome in 3 cases post-penetrating injuries. 2 cases had chronic retinal detachment following late presentation of blunt trauma and had PL negative vision post-cataract surgery. So coming to discussion, we obtained a satisfactory visual outcome in children with traumatic cataracts. Blunt trauma had better final visual acuity than penetrating injuries. In case of penetrating injuries, we preferred repairing corneal laceration first and performing cataract surgery when the inflammation subsided after 4 to 6 weeks on an average. PCL implantation with 3-piece IOL was preferred in all cases along with phacoaspiration, which was done successfully. Rate of PCO formation has been reported to be higher in pediatric eyes with traumatic cataracts as compared to the non-traumatic cataracts. But in our study, this incidence was low as primary posterior capsular rhexis or PCC of 3 to 4 mm size was done in all cases, which maintained a clear visual axis and also reduced the incidences of pupillary optic capture. So we recommend phacoaspiration with PCIOL, PCC and anterior vitrectomy in children with posterior capsular plaques, anterior capsular tears or thickened membrane and also in older children. In children to prevent stimulation deprived amblyopia, surgery is done as soon as possible with intermittent patching of the other eye to avoid amblyopia. Intensive topical steroid therapy is given for a long period, say about 2 months in a slow tapering phase to avoid post-op inflammation and uveitis, which is more common in pediatric traumatic cataracts. So here is an example of a case where a thickened fibrotic plaque is successfully removed by initiating with the help of a cystitome cut with a 1 followed by traumatic cataract extraction and successful implantation of IOL in the pediatric patient. To conclude, early management of primary corneal tear, depending on its location, followed by traumatic cataract extraction with IOL implantation can result in a better visual outcome. Blunt trauma had better final visual acuity than penetrating injuries. Eyes that underwent primary posterior capsular rhexis in a clear corneal area plus anterior vitrectomy combined with lens aspiration, IOL implantation had better final visual outcomes. Penetrating injuries, being the most common type of injury, necessitates adequate preventive measures in the form of parental counseling, child awareness drives in schools with emphasis on adequate precautions, preventive measures and immediate ophthalmic consultations in the event of an injury. These are my references and thank you.
Very nice presentation and good take-home messages. But one question is that any patient who had a corneal trauma with capsular tear, when did you intervene in those patients the second time after the primary corneal tear repair?
Sir, actually depends upon if there is a cortex disturbance associated with it. But if there is a cortex disturbance or if there is an ALC tear also, first we would like to go for the primary corneal tear repair. And we would like to give medical management depending upon the etiology of the injury. Say if it is a stick injury or a vegetative matter injury, we would not put it on steroids. Post-op management will be more of antibiotics, antifungals. But still we would like to wait till the inflammation subsides at least for 1 to 2 weeks, because when there is inflammation, there is always association of endophthalmitis can happen. And we want to go for PPC for every case. So if you are doing a PPC, there is a disturbance of anterior vitreous phase. And when there is a disturbance of anterior vitreous phase, then high chances of endophthalmitis can happen. So we would like to see the timing. We have to titrate case to case basis. So primary corneal tear repair followed by we have to observe the patient. If the inflammation has subsided, if the patient is doing well, then we can take it in 1 to 2 weeks if there is a cortex disturbance. But if there is any no cortex disturbance, we can wait till 4 to 6 weeks. So that's what we normally follow.
What was the incidence of pupillary block glaucoma in these cases?
Pupillary glaucoma, normally we have not found, sir, madam, because we normally do a prophylactic PI before after doing the cataract extraction. So normally we have not found, and we always in a post-operative medical management, we do add Timolit.
How did you calculate the IOL calculation, the A scan?
A scans are of the better eye, because penetrating injuries and with scar, it is always very difficult to get for the affected eye. So for the better eye, whatever like we have done with that.
So whatever you got for the better eye, the
Yes,
fellow eye, you had put the same implant.
Approximately.
Is there any role of pentacam or topography or doing for both the eyes to see the astigmatism, or a B scan?
Sir, in those cases where we have waited for 4 to 6 weeks, we used to do, we have done for only few cases, topography to see how much is the astigmatism, and if it is necessary, we could have gone for a selective suture removal so that the astigmatism is less. But then as a protocol, we have not done for every case.
And there's another important factor is that you should always see the refractive error. In case the child is wearing glasses, check
Yes.
for the refractive error for the fellow eye. That will give you more accuracy towards your IOL power calculation.
And B scan comparison also helps,
Yes,
I think,
that
sir.
is what I
like
What was the age group of these patients?
Sir, on an average from 4 to 12 years, sir, in a little...
So you used to do PCC in all these cases?
Yes, sir. Our pediatric doctor has done for every
And
case.
PCC with anterior vitrectomy?
Yes, sir.
Right, thank you. And one more suggestion. This is probably your first or second time. When you speak a little slowly. You were running. So it takes a little time for all the others to
Sorry, sir,
understand.
head and
You'll
interest.
get used to it with passage of time. But
Thank you, sir.
good. Thank you.